So if you're in the building, this is your opportunity to run down to Fustanellis and get coffee and mocktails on behalf of rehab rounds. So if you're online, run quickly. All right, I will get started with introductions here. So Dr. Terada has the full time for his presentation. So welcome to Cardiac Rehabilitation Rounds. I'm Jennifer Reed. I serve as the program chair for cardiac rehab here at the University of Ottawa Heart Institute. This is our second year offering formal cardiac rehabilitation rounds, which are every other month between September and May. We host a virtual format, both in person in Fustanellis and online, to hopefully meet the flexibility of everyone's needs. We are particularly honored. I'm thrilled this afternoon. We're hosting Dr. Tasuku Terada, who's actually a former postdoctoral fellow here in the Division of Prevention and Rehabilitation at the University of Ottawa Heart Institute. So Dr. Terada is an American College of Sports Medicine certified clinical exercise physiologist with more than 10 years of experience in clinical exercise physiology. He earned a PhD in exercise physiology from the University of Alberta, one of the world's top-ranked sports research institutes, and worked with the Bariatric Care and Rehabilitation Research Group in the Faculty of Rehabilitation Medicine as a postdoctoral fellow. Upon that fellowship, he was recruited to the Exercise Physiology and Cardiovascular Health Lab in our Division of Cardiac Prevention and Rehabilitation. I will say during his tenure year was probably some of the most productive years for the Division of Prevention and Rehabilitation with regards to research outputs, not only including manuscripts, but also for funding. So I'd like to personally thank him for those years that he spent with us. So now we watch him flourish as an assistant professor in the School of Life Sciences at the University of Nottingham, UK. He's getting well-versed in the wet, dark days of the UK compared to the cold, bright days of Canada, and still stays very much involved in research here at the University of Ottawa Heart Institute. His independent research program focuses on examining various exercise modalities to prevent and manage chronic conditions such as obesity, type 2 diabetes, and cardiovascular disease, which profoundly impacts the well-being of afflicted individuals. So without further ado, I will pass it over to Dr. Terada to begin his presentation, and then we'll hopefully leave about 10 minutes or so for questions and answers at the end. So thank you very much and enjoy.
Okay, thank you very much for this kind introduction. Hope you can hear me. And I'm very happy to be virtually back to this familiar room. I spent quite a few years at the Heart Institute before I moved to the UK. And I really miss the days when I sat in the Fust and enjoyed the talks and the pizza for my lunch. So I'm very happy for this opportunity to present some of my work that I completed at the Heart Institute and some follow-up work from the UK. I have nothing to declare. So Jennifer gave a nice introduction, but for those of you who don't know me, I'd like to very briefly introduce myself. My journey started in Japan when I became interested in exercise science. And then after graduating from my high school, I moved to the United States and studied exercise biology. And I subsequently moved to Canada to complete my graduate work and a few fellowships in different Canadian institutions. I spent close to 6 years in the Heart Institute during this journey, and that was one of my best research experiences I've had throughout this my career. And in 2023, I moved to the UK, and I'm currently an assistant professor at the University of Nottingham. I feel like this happened very quickly in a blink of an eye, but looking at how much our kids have grown, it makes me realize it's been quite a journey. And now our kids are old enough to say no to my photo request, but I'm very, very grateful. My family joined me for this journey, and they traveled all these different places with me. So this slide summarizes my research areas, as I have been to different institutions and worked in different fields. My research areas have become pretty broad, but exercise has always been a center of my research. And I'm very interested in tailoring exercise prescriptions to prevent or manage clinical conditions that includes obesity, type 2 diabetes, and cardiovascular disease. And as you know, these conditions are well connected. Obesity is a risk factor for type 2 diabetes, and both obesity and type 2 diabetes increase the risk of cardiovascular disease. And exercise plays very important roles at each stage to manage the conditions or prevent the conditions from advancing. And I'm very interested in identifying what types of exercise works best for people with the different clinical conditions. So a quick background on exercise as a medicine. I'm a clinical exercise physiologist, and I believe exercise is a medicine to treat various conditions. And this idea dates back to BC 400 when Socrates mentioned the importance of exercise for health. He mentioned that, if we could give every individual the right amount of nourishment and exercise, we would have found the safest way to health. If there's any deficiencies in food and exercise, the body would fall sick. Walking is the best medicine, and I agree. And all parts of the body, if used in moderation and exercised, become healthy and well-developed and age slowly. But if they are unused and left idle, they become liable to disease, defective in growth, and age quickly. So he basically covered the most important aspects of exercise medicine more than 2,000 years ago, but we have a few more exercise options these days, different exercise intensities, different exercise modalities, aerobic exercise, resistance exercise, and how best to prescribe these varied exercise types. And protocols is a major focus of my research. One type of exercise I am particularly interested in is high intensity interval exercise, or HIIT. When putting this presentation together, I realized that I've been studying this particular protocol for over 10 years. I started my PhD focusing on the role of HIIT in people with type 2 diabetes, and then apply this protocol to patients with cardiovascular disease. Prescribing HIIT to patients with type 2 diabetes was based on a fairly simple idea because high intensity metabolizes more carbohydrate or glucose. I thought this might be a better method to control blood glucose in people living with type 2 diabetes. And then this got me interested in its effect on other physiological measures. And when I started my second fellowship at the Heart Institute, I had an opportunity to apply this protocol to patients living with the different cardiovascular conditions and study its effect on these patients. I think most of you are fairly familiar with the HIIT exercise intervention. It's been used at the Heart Institute and many other cardiovascular rehabilitation programs adapting this protocol in addition to traditionally used moderate intensity continuous exercise training, or MICT. It is basically a combination of high intensity bouts and lower intensity recovery phases, so it can be performed in many different forms. The idea is to have patients accumulate more time at high intensity without making them prematurely fatigued by giving breaks in between high intensity bouts. And this figure in blue to the top left is one example of MICT, or participants exercise, at a given moderate intensity for the duration of the session. And the one shown to the right is one example of a HIIT, which can take many different forms. And one of the most established HIIT protocol is called Norwegian protocol, and this is shown in the bottom middle figure. It consists of 4 minutes at high intensity, followed by 3 minutes of active recovery, and high intensity exercise is often prescribed as above 90% of peak heart rate. This is also referred as high volume HIIT, as the total volume of HIIT high intensity bouts is relatively large. And there's also a low volume HIIT, which consists of shorter bouts of high intensity exercise interspersed by shorter active recovery. One example is shown in the figure to the left. And there's also a HIIT protocol that includes full recovery before moving on to the next high intensity bouts, and that's shown to the right. So by altering the duration of exercise and the intensity of the exercise, or changing the duration of recovery phase or intensity of the recovery phase, or changing the number of repetitions, it can be prescribed in many different ways. So the Norwegian HIIT protocol is probably one of the most established protocol in cardiac disease populations, and this is the landmark study that led to many subsequent studies applying HIIT to people with cardiovascular disease. This study was published in 2007, and it basically divided 27 patients living with heart failure into 2 different exercise training groups. One was the Norwegian HIIT program that performed 4 bouts of 4 minutes high intensity exercise at 90 to 95% of peak heart rate, which were interspersed by 3 minutes of active recovery. And the other group performed MICT, which was at 70 to 75% of peak heart rate for 47 minutes per session. There was also a control condition, which I will not discuss here. You would expect some improvements following exercise compared to no exercise control condition. And indeed, that's what was seen in the study. And the key here is the degree of changes between mixed and HIIT. And these researchers designed the two exercise groups to be isocaloric, meaning that the total exercise volume or energy expenditure were calculated to be identical for the two groups to tease out the effects of exercise intensity. So before and after each of these conditions, which were performed 3 times per week for 12 weeks, cardiac function, endothelial function, and the cardiorespiratory fitness were measured. I'll just highlight some of the major findings. First, they found significant differences between the two exercise modalities in the cardiovascular function. Stroke volume and the cardiac output only increased in HIIT, and ejection fraction increased significantly more in HIIT compared to mixed. Endothelial function measured by flow-mediated dilation also increased significantly more in the HIIT. And when it comes to cardiorespiratory fitness, there was a large difference in the degree of improvement, with about 1.9 milliliter per kg per minute, which is about 0.5 METs improvement following the mixed, and 6 milliliter per kg per minute, or close to 2 METs increase in HIIT. So about 3 times larger increase in cardiorespiratory fitness following the HIIT protocol. And according to this recent study, 2 METs improvement translate into a greater than 30% reduction in mortality risk in patients with the cardiovascular disease. So this study showed greater effects of the Norwegian HIIT and highlighted the importance of exercise intensity. These findings are unfortunately not supported by larger scale studies in patients with heart failure. This is a multi-center randomized controlled trial that included 260 participants with heart failure, FRF. And consistent to a previous study, there were a Norwegian HIIT group, mixed, and a control group. And again, for the interest of this presentation, I will just focus on HIIT and mixed. And they prescribed the same protocol as the previous study, but this study showed no difference in changes in VO2 peak or ejection fraction after 3 months between HIIT and mixed. Notably, the improvements seen in HIIT was much smaller than what was seen in the previous study. So following the HIIT, there was only 0.9 milliliter per kg per minute increase in VO2 peak, which was much smaller than what was seen in the previous study that showed 6 mil increase in cardiorespiratory fitness. So part of the reason they did not show significant differences between the HIIT and mixed groups may be due to low adherence to the prescribed exercise. This was a letter that was published following the publication of the multi-center RCT. And these authors highlighted that the majority of the study participants did not perform HIIT or mixed according to the prescribed intensity. They're basically saying that mixed group exercise at higher than prescribed intensity, while the HIIT group exercise at intensity too low. And these are certainly a limitation of the study, and the original study did report the difficulty of implementing this protocol to a larger population. So when the sample size is small, and when researchers have a great control over exercise interventions, high volume HIIT or the Norwegian protocol seems to have greater benefits compared to mixed. But I would also think it is probably difficult to bring the heart rate up to the desired range, often 90–95% of peak heart rate, and maintain that heart rate for the duration of the high intensity bouts, especially when supervisors have to oversee the exercise of many patients. We also conducted an RCT comparing the HIIT, mixed, and Nordic walking in patients with coronary artery disease. So this is a study led by Dr. Reed. We randomized 130 patients with a CAD into one of the 3 groups, and they all exercised twice a week for 12 weeks. We used a high volume HIIT protocol similar to the Norwegian protocol, but it was performed in several different ways, such as dancing moves, walking, and biking. And each HIIT session was 45 minutes in duration. For mixed and Nordic walking, they were performed at moderate intensity, and they lasted 60 minutes per session, so slightly longer than HIIT, and all groups exercised twice weekly for 12 weeks. The primary outcome was 6 minutes walk tested distance, so it was not VO2 peak, but we found a similar improvements in the walking distance between HIIT and mixed, and it was the Nordic walking group that improved the most. And this greatest change in the Nordic walking group may be due to greater involvement of upper body and increased coordination, or it could have been due to an alignment of the training modality and the outcome measures, because Nordic walking is primarily a walking exercise, and 6 minutes walk test is also a walk test. Nordic walking may have had the biggest impact on the walking distance of these patients. And the important finding here is that despite the high volume Norwegian HIIT protocol we used in this study, we also did not see any difference between the HIIT and the mixed group in 6 minutes walk test distance. So because of the difficulty of implementing high volume HIIT to patients with cardiovascular disease in the larger scale studies, we tested the effects of low volume HIIT in patients with atrial fibrillation. This is another study by Dr. Reed, randomizing 94 participants with atrial fibrillation into low volume HIIT and MIGT. And as shown in this figure, the low volume HIIT used in this study consisted of 30 seconds at high intensity exercise, interspersed by 30 seconds lower intensity exercise. So the total exercise volume of HIIT was lower in, total exercise volume was lower in HIIT, which only involved 23 minutes per session, whereas the MIGT group exercised for 60 minutes per session. This figure is an example of a power output and heart rate response to the low volume HIIT. We recorded heart rate and power output to make sure each participant completed exercise at the given exercise intensity and found high compliance to the prescribed HIIT, which is not different from the MIGT group. And a table to the right summarizes our findings. What we found, no differences in changes in 6 minutes walk test distance or quality of life between HIIT and MIGT following 12 weeks of exercise interventions. It showed that with reduced exercise volume, it can achieve a similar improvement compared to larger volume MIGT. So based on this, we concluded that twice weekly 23 minutes HIIT was as efficacious as a twice weekly 60 minutes cardiac rehab in improving functional capacity, general and disease-specific quality of life, resting heart rate, and the physical activity levels in patients with a persistent and permanent AFib. We summarize these effects of a HIIT in different cardiovascular disease populations in our recent publication in APNM. And in this review, we summarize the effects of HIIT in different cardiovascular disease population, which included coronary artery disease, heart failure, atrial fibrillation, patients with implantable electronic devices, and peripheral artery disease. And our main conclusion was that the magnitude of improvements following HIIT may differ across varying protocols. And in my opinion, Norwegian HIIT protocol or high volume HIIT protocol seems to produce the greatest improvements in cardiorespiratory fitness if it is implemented as designed. But it might be challenging to implement, especially when the number of patients or participants increases. And the low volume HIIT is probably easier to implement. However, its effect does not seem to be as big as high volume HIIT. And what I'd like to emphasize here is that HIIT, especially low volume HIIT, can reduce the time commitment to exercise. And this is an important message as people often don't have enough time to perform exercise. If similar benefits can be achieved by a smaller amount of time, that's an important benefit of high intensity interval exercise training. And this time efficiency of HIIT may provide time to perform other types of exercise for further health benefits, such as resistance exercise training. So that's how I got interested in resistance exercise training, especially combining aerobic and resistance exercise training in people with cardiovascular disease. Resistance exercise has been recommended for patients with cardiovascular disease, but it's rarely recommended or prescribed by itself. And it's often prescribed in conjunction with aerobic exercise training. So I was not just interested in resistance exercise by itself, but how it adds to the benefits of aerobic exercise training. I'm also interested in how to add resistance exercise. We know it's best to perform both, but oftentimes patients with cardiovascular disease or even general population don't have time to perform additional exercise. If patients do not have time to add resistance exercise on top of aerobic exercise, I was curious to find out if patients could benefit from replacing part of aerobic exercise with resistance exercise, or does it have to be added to aerobic exercise? So there are different exercise guidelines for different clinical populations, but they are fairly similar in that most of them recommend at least 150 minutes per week of moderate intensity aerobic exercise, more than 2 days per week of resistance exercise, and combine the two for better benefits. And this figure shows the proportion of older adults meeting aerobic exercise, resistance exercise, and aerobic and resistance combined exercise recommendations by different age groups. And as you can see from the figure, the prevalence of participating in exercise decreases as the age increases. More adults meet the aerobic exercise guidelines, which is shown in blue bars. And compared to that, fewer older adults meet resistance exercise recommendations, as shown in the orange bars in the middle. And obviously, these people participate in the combined training. Those at the age of 65 to 69. Less than 20% meet the exercise recommendation for both aerobic and resistance exercise training, and this falls to below 10% by the age of 80. So the key message here is that more people tend to engage in aerobic exercise, but less are likely to perform resistance exercise. And when it comes to both aerobic and resistance exercise, only a small proportion of older individuals engage in this type of exercise training. And although this data is from healthy older adults from the US, I would expect to see a similar distribution in Canada. And some study reports that those with clinical conditions, including cardiovascular disease, are less likely to participate in resistance exercise training. So you'd expect to see a smaller number of people being engaged in resistance exercise or aerobic and resistance combined exercise in clinical populations. So in a way, I'd say resistance exercise may be the most underutilized behavioral medicine for people with chronic health conditions, including cardiovascular disease. Resistance exercise can be applied to people with a different status and conditions that include older individuals, both females and males, and adults living with chronic health conditions, such as cardiovascular disease. And it can also be performed in many ways: body weight or calisthenic type of exercise, resistance or rubber bands, weight machines, or free weights. And many studies have supported the benefits of these different types of resistance exercise training. Resistance exercise by itself can improve cardiorespiratory fitness or VO2 peak in deconditioned individuals. So it's not just aerobic exercise, but resistance exercise can also improve the aerobic capacity of those who are deconditioned. And you can obviously improve body composition by increasing muscle mass. It also improves endothelial function, quality of life, psychological health, including depression and anxiety. So aerobic exercise can improve all these health measures, but resistance exercise can also have positive effects on these health measures. These important benefits on different aspects of health measures will also reduce the risk of cardiovascular and all-cause mortality, as shown in the figure, in healthy adults. Compared to those who do not engage in resistance exercise, this review showed engaging in resistance exercise is associated with 17% lower risk of cardiovascular-related mortality, and also 15% reduced risk of all-cause death in those who engage in resistance exercise compared to those who do not perform any resistance exercise. When combined with well-established effects of aerobic exercise, combined training leads to further improvements in some, but not all, cardiometabolic risk factors. So both aerobic and resistance exercise have relatively small impact on blood lipids profiles, and aerobic and resistance exercise do not seem to have additive effects on these measures. One reason we often see small effects of exercise on blood pressure lipids is a patient these days often have relatively well-controlled blood pressure and lipid profiles due to a medication, and there's not much room for exercise to improve these measures. And compared to that, oftentimes there's more room for improvements for blood glucose and body mass. And because both aerobic and resistance exercise have a positive impact on blood glucose and body mass, you can expect to see a greater benefit when these two are combined. And by combining the two exercise types, you can expect to see better results on weight maintenance as well. Some of these additional benefits of aerobic and resistance combined training may translate to reduced mortality. And this meta-analysis, for example, showed 46% reduced the risk of cardiovascular disease related mortality as compared to those who do not engage in any forms of exercise, and 40% reduced risk of all-cause mortality in those who engage in both aerobic and resistance exercise training as compared to those who do not perform either of them. So the effects of aerobic and resistance combined exercise training was less clear in patients with coronary artery disease. Some study examined the effects of combined training, but they were small in sample size. And some systematic reviews also did not have rigorous study design or were conducted more than 10 years ago. So we conducted this systematic review, which was published in last year in 2024. And in this review, we compared the effects of combined exercise training and aerobic exercise training alone in patients with a CAD. Again, because resistance exercise is rarely prescribed by itself in patients with cardiovascular disease, we're particularly interested in its effects combined with aerobic exercise training. We also knew that exercise was better than control or no exercise, so we did not include a control group, but rather used aerobic exercise only as a control condition to assess the effects of aerobic and resistance combined training in comparison to aerobic training alone. So in a simple way, the question was whether performing both aerobic and resistance exercise was better than performing aerobic exercise alone in improving cardiovascular disease risk indicators that included cardiorespiratory fitness, blood glucose and lipids, and body composition in patients with coronary artery disease. We also performed subgroup analysis looking at the effects of aerobic interval exercise and aerobic continuous training separately. And additionally, we were interested in the effects of exercise volume on the outcomes. So another subgroup analysis compared the effects of a combined exercise training that added resistance exercise without reducing the aerobic exercise volume compared to the aerobic exercise alone. And the effects of a combined exercise training would reduce the aerobic exercise volume to add resistance exercise compared to aerobic exercise alone. So in one group, the volume was greater for the combined exercise training group because of the addition of resistance exercise. But in another subgroup, because the portion of aerobic exercise was replaced by resistance exercise, time commitment was fairly similar between the two groups. And I'm very confident this was a more thorough review that included more studies than any similar comparisons in previous reviews, thanks to the help of the librarian from the Heart Institute, Sarah, who identified more than 17,000 articles and more than 13,000 abstracts for us to screen. So it was a lot of work to go through all these studies, but I think it was worth it. We ended up including 23 studies with a total sample size of 916 patients with coronary artery disease. So of these 23 randomized controlled trials, 8 prescribed aerobic interval training, and the training duration ranged from 4 weeks to 8 months. Most studies used the machine-based resistance exercise training. As we had expected, we saw better improvements in body composition following combined training compared to aerobic training alone. Lean body mass increased more in those who performed both training, and body fat was reduced in those reduced to a great extent in those who performed both resistance and aerobic exercise training. And interestingly, we also found that combined training improved cardiorespiratory fitness more than aerobic exercise training alone. This was different from previous reviews, which did not show significant difference between the combined and aerobic exercise training alone in cardiorespiratory fitness measured in VO2 peak in patients with the CAD. And I would suspect inclusion of larger number of studies and having a greater power to detect the difference had contributed to this inconsistent findings. And when we looked at the changes separately for the combined training with reduced aerobic exercise volume and without the reduction of aerobic exercise training volume, we found that the combined training group that did not reduce aerobic exercise training volume improved cardiorespiratory fitness significantly more than aerobic exercise alone. And in contrast, when the volume of aerobic exercise was reduced to add resistance exercise, there was no significant difference between the combined and aerobic training alone. So unfortunately, it still remains a bit unclear if greater increase in VO2 peak is due to the effects of adding resistance exercise or due to the greater total exercise volume. And because there were a few studies that examined the effects of interval exercise training combined with the resistance exercise on cardiorespiratory fitness, we were unable to identify the combined effects of HIIT and resistance exercise training. And there were no differences in changes in lipids or glucose between the groups. So here are some takeaways from this study. We know that high cardiorespiratory fitness is strongly associated with lower risk of cardiovascular or all-cause mortality, and we found that an increase in cardiorespiratory fitness can be enhanced by adding resistance exercise training to aerobic exercise training. We also found that by replacing some portion of aerobic exercise with resistance exercise, body composition can still be improved more without compromising the increase in cardiorespiratory fitness. And if there's no time to perform both aerobic exercise and resistance exercise in full, replacing some part of aerobic exercise with resistance exercise will still increase cardiorespiratory fitness, similar to aerobic exercise training alone, but comes with improved body composition, such as reduced percent body fat and increased muscle mass. Overall, the findings of the study supports the current exercise guidelines that recommends resistance exercise in addition to aerobic exercise for further benefits. So the best case scenario is to add resistance exercise to aerobic exercise without reducing the volume of aerobic exercise for further increase in cardiorespiratory fitness. But our review also showed that dropout rates increases in the studies that added resistance exercise to aerobic exercise. And this suggests that increased duration of exercise sessions due to addition of resistance exercise probably makes it more difficult for patients with a CAD to tolerate. And to address this, I thought adding resistance exercise to time-efficient, high-intensity interval exercise would be important. But as I said, we found only 8 studies that combined interval training and resistance exercise training. And 3 of them used very high volume interval, with each interval lasting 10 minutes, and 4 used intervals lasting 5 minutes. So these are very high volume, not high intensity interval, but more intensity or lower intensity interval training. And the intensity of intervals was not, as I said, not necessarily high. 2 used light to moderate intensity, 1 used moderate intensity, and 2 used moderate to vigorous intensity. So this area needs to be expanded more to examine the effects of combining low volume HIIT and resistance exercise training to see if there are any additional health benefits without increasing time commitment and dropouts potentially. Another important findings from this review is the underrepresentation of women in these studies. Of 916 participants with the CAD altogether, less than 30% was women. And this is similar to the proportion of women in many cardiovascular disease studies. And in our review, 2 studies included exclusively women, while 7 included only men. And women generally live longer than men, but experience higher rates of diffuse muscle atrophy that can lead to frailty and disability. But despite these risks, women are less likely to be physically active, and they are especially less likely to engage in resistance exercise training. And this figure to the right is data from the UK. It shows that proportion of women meeting the recommendation based on different definitions of resistance exercise. And based on the most stringent definition, which is more than twice a week of resistance exercise defined in the 2019 UK Physical Activity Guidelines, only 5.6% of women met resistance exercise recommendation. So in my opinion, this is a group that requires more resistance exercise, but more studies are also needed in this area. So this is a very preliminary results from this systematic review focusing on women only. There were 2 studies that exclusively included women, and a few more studies included some number of women in their studies. And since sex-specific data were not available, I contacted these authors to retrieve the data of women, but I'm still waiting to hear back from a few. And at the moment, these first plots includes all the available data. And as you can see from the figure, no significant difference between the effects of combined training and aerobic training alone in women with the CAD, but the data points towards greater benefits of combined training on cardiorespiratory fitness in women compared to aerobic training alone. So once I receive more data from the other authors, hopefully I can come up with a more definitive conclusion. Yeah, I think more studies are needed to address the effects of resistance exercise in women with cardiovascular disease. So with some interesting findings in patients with coronary artery disease, we are now conducting a similar review on patients with heart failure. So now for the last few minutes, I'd like to share some of our preliminary findings from our ongoing review, examining the effects of combined exercise training in patients with heart failure. And I have to emphasize, this is very preliminary, as some data still needs to be verified, but I just want to share some of our findings on the role of aerobic and resistance combined training in patients living with heart failure. And I also need to highlight that the results I'm sharing today focus on heart failure with reduced ejection fraction, HFrEF only, just because there were a few studies that had unclear description of the patient's heart failure conditions. And I'm still waiting to hear back from some of the authors to clarify what they are. So this is preliminary data from patients with HFrEF only. So heart failure is another form of cardiovascular disease that significantly reduces patients' functional capacity and quality of life. So this is a study recently published in Nutrition led by Dr. Noda and Dr. Kamiya, both of whom spent some time at the Heart Institute in EPCHL. And in this study, they looked at the association of dyspnea, which is reduced whole body muscle strength, determined by the combination of grip strength and leg strength, and the risk of mortality in patients with heart failure. And here they retrospectively assessed the association between the conditions of dyspnea before and after cardiac rehab and the risk of mortality. And they divided these patient groups into 4 groups that included non-dyspnea at the baseline and the follow-up, dyspnea at the baseline but no dyspnea at follow-up, dyspnea at baseline and the follow-up, and non-dyspnea at baseline but dyspnea at follow-up. And they found that compared to those who had no dyspnea at baseline and follow-up, those who developed the dyspnea over time, or those who did not improve the condition of dyspnea, had a higher risk of mortality, which highlights the importance of muscle strength for better survival. And also, this is the figure I showed you earlier, showing the association of the change in cardiorespiratory fitness and the risk of mortality. So if you can increase the cardiorespiratory fitness, you can reduce the risk of mortality. But if cardiorespiratory fitness deteriorates, the risk of mortality increases. So in patients with heart failure, improving both muscular strength and cardiorespiratory fitness play an important role to reduce the risk of mortality. So this is our ongoing review, and the protocol for this review was very similar to what I showed you for the patients with the CAD. Our target population was those with heart failure. That includes those with the reduced ejection fraction and preserved ejection fraction. And we searched for randomized controlled trials comparing the effects of combined exercise training and aerobic training alone on cardiorespiratory fitness, 6 minutes walk test distance, other functional measures, and cardiac function, which included ejection fraction, stroke volume, and cardiac output. The subgroup analysis was also similar to our previous study. One analysis focused on exercise volume, so combined training with or without reduced aerobic exercise volume. And another subgroup sub-analysis focused on aerobic exercise types, continuous and interval exercise. There were quite a few high-intensity interval exercise studies in patients with heart failure, so we were expecting to find more studies that combined HIIT and resistance exercise. And we will also look at HFrEF and HFpEF separately, but for today, I'll just be presenting the results from HFrEF as we're still in the process of identifying the type of heart failure in some studies. But majority of the studies we identified were on patients who would have HFrEF. So the data I'm presenting today do represent majority of the studies we included in this analysis. And in collaboration with the researchers from Japan and also from Slovenia, we've just finished identifying studies and are in the process of extracting data. Very similar to our previous review, we searched 6 major databases, registries, and conference abstracts, and identified about 10,000 studies. And after removing duplicates, we screened about 8,000 papers and then identified 25 studies that met our inclusion criteria. And I believe we did thorough research and identified more studies than previous reviews. So this slide summarizes the effects of combined training compared to aerobic training alone on cardiorespiratory fitness with a subgroup analysis with the studies that reduced the volume of aerobic exercise training on top and the studies that did not reduce the volume of aerobic exercise at the bottom. As you can see from the figure, more studies reduce the volume of aerobic exercise to add resistance exercise training. And in fact, many of these studies use the same exercise duration for each session. So if, let's say, aerobic only group exercise for 60 minutes per session, the combined group did 40 minutes aerobic exercise and 20 minutes resistance exercise. So the time commitment or the duration of each session were the same in these studies. And overall, we found that combined training group improved cardiorespiratory fitness significantly more than aerobic training alone. And when we look at the results from the subgroup analysis, we found that the subgroup with reduced aerobic exercise volume significantly improved cardiorespiratory fitness compared to aerobic training alone. And for the subgroup that added resistance exercise to aerobic exercise without reducing the volume, we did not see any difference compared to aerobic training alone, in contrast to what we had expected and in contrast to what we saw in patients with the CAD. And these studies seem to favor aerobic training alone. But there were only 2 studies that added resistance exercise without reducing the volume of aerobic exercise. So this could simply be due to chance, but we will take a closer look to see what the potential explanation may be. I think the most important findings presented here is that when time-matched combined and aerobic training alone were compared, cardiorespiratory fitness increased more in the combined training group. And because there was a significant heterogeneity, which is basically the inconsistency of the outcomes among the studies, we will look into the quality of these studies and do more rigorous analysis to see the robustness of these results. But this suggests the potential benefits of replacing some parts of aerobic exercise with resistance exercise for further benefits on cardiorespiratory fitness. So this slide also shows the results on cardiorespiratory fitness while grouping the studies based on aerobic exercise types, HIIT and continuous exercise. And obviously the overall outcome remains the same because we're just comparing the same studies, but they're just organized in the different ways. We have HIIT in the top on the top and mixed at the bottom. And the results were a bit more consistent for the studies using continuous exercise with no significant heterogeneity. And compared to continuous exercise alone, the combined training had a greater impact on cardiorespiratory fitness. And for HIIT, there was no significant difference between the combined and HIIT alone. So again, given its significant heterogeneity, we'll perform further analysis to see if we can identify the source of variability between the studies. And our next step will be to look into the types of interval training used in these studies, the prescribed intensities, duration of the bouts, and also the study qualities to see the robustness of the results. So this slide shows the results of a 6 minutes walk test distance. There were not enough studies that used the interval training combined with the resistance exercise training to assess their effects. So this result is from continuous exercise training only. But by pulling all these 5 studies, we saw significantly greater improvements in 6 minutes walk distance in the combined training group as compared to aerobic training alone. And lastly, this slide compares the effects of aerobic training alone and combined training on ejection fraction. We do have other cardiac function measures, but this is the only one that's available at the moment. And overall, we saw no significant differences between the combined and aerobic only group. And this is in line with the previous review that showed no additional benefits of resistance exercise or combined exercise on left ventricular ejection fraction. But looking at the HIIT group, HIIT combined with the resistance exercise seems to be doing somewhat better, but sample sizes were fairly small in these studies, 20 in each group. So we just need more study to draw more meaningful conclusion. So in summary, available evidence indicates that HIIT is time-efficient aerobic exercise that can improve various health measures, including cardiorespiratory fitness, to a similar or greater extent compared to moderate intensity continuous exercise training. When aerobic exercise is added to resistance exercise, it would further improve cardiorespiratory fitness more than aerobic training alone in patients with a CAD. Also in patients with a CAD, when a part of aerobic exercise is replaced with resistance exercise, this does not seem to compromise the improvements in cardiorespiratory fitness, but it can also lead to enhanced improvements in body composition, such as increased lean body mass and reduced percent body fat. And because adding resistance exercise to aerobic exercise increase the time demands and potentially the dropout rates, combining low volume HIIT and resistance exercise may be an approach to obtain benefits of both types of exercise while not increasing time commitment as much. But more studies are needed here, as limited number of studies have looked into low volume HIIT combined with resistance exercise in patients with the CAD. In patients with heart failure, again, this is very preliminary results, but these results suggest that aerobic and resistance combined training may increase cardiorespiratory fitness and also 6 minutes walk distance, both of which likely leads to reduced risk of mortality. And the figure to the right is a very rough indication of the effects of aerobic and resistance combined training compared to aerobic training alone. I would expect to see greater improvements in some of these areas following the combined training compared to aerobic training alone. So again, as guidelines suggest, I would recommend adding resistance exercise to aerobic exercise training for further benefits for better management of cardiovascular disease. So with that, I'd like to thank the University of Ottawa Heart Institute and especially Dr. Jennifer Reed for this opportunity to present some of my work and also a great experience as a research fellow. I also like to thank all my collaborators for their hard work on these reviews I presented today and all my colleagues that I worked with for different projects. And last but not least, I'd like to thank everyone for listening. And if you are doing aerobic exercise, that's great. If you are not engaged in resistance exercise yet, hopefully I was able to convince you a bit to add this to your training. Thank you very much for listening, and I'm happy to take any questions.
Thank you very much, Dr. Terada, for an excellent presentation. I think we're all sitting here thinking about resistance training, and we probably are likely not doing enough given the number of females in the room here as well. I'm going to start off with a broad question as the questions come in. We do have some so far. Most cardiac rehabilitation programs across Canada and internationally, and even chronic disease management programs, resistance training is always an element at the end of exercise sessions that's combined with flexibility. It's almost treated as we know we must incorporate some element, but it's not very standardized or rigorous for most programs. It's usually 5 or so minutes at the end, following aerobic exercise training. I'm wondering, from the work that you've done to date, might you have any suggestions in terms of formalizing some of the resistance training programs that exist within cardiac rehab or chronic disease management, or what some of your general recommendations might be to any of these programs?
I think cardiac rehab is the best place to really engage in exercise, resistance exercise training. People, I think, engaging in aerobic exercise is generally, I won't say easier, but somewhat easier for who are naive to exercise. But resistance exercise, there seems to be a more barriers to engage in this type of exercise. So if cardiac rehab can really show them how to engage in resistance exercise, I think that would really benefits the patients. Most of the studies, so these are studies, so they had a different way to implement resistance exercise. They really supervise these patients and then have them go through mostly machine-based exercise training. And that really showed important benefits of adding this resistance exercise training. So I know it's part of the cardiac rehab, but if it can be, and I understand that the time is limited for these patients to exercise, but if it can be a major part of the exercise training within the cardiac rehab, I think that does benefits patients a lot.
Thank you. Okay, the questions are rolling in online, so I'm going to make Dr. Housen here wait a few minutes before he gets to the mic. So the first question is, what kind of exercises can you suggest for people with coronary microvascular coronary disease? And there is an email address provided here, so if you want to think on those specific recommendations, we can connect you with the person and the email address.
Yeah. Okay. Yeah. I'll probably have to look up and see what's the best way for that particular population group. So I may need some time. But I do suggest that Heart Institute provides a nice resource for type of resistance exercise for patient populations, rubber band exercise, calisthenic exercise. So resistance exercise doesn't really have to be intense weightlifting. It can be performed in many different ways. And I always encourage people to start with more reps, lower weight, and then just build up on that to increase the weight and reduce the reps. So I think regardless of the populations, I think like the key message is to start with lower resistance, start slow, and then gradually build up on that. I think that's a key strategy.
Okay, thank you. Question 2, does it matter what order the strength training occurs relative to aerobic training, i.e. do we start a session with strength or end it with strength?
That's a great question. I was interested in that when I was studying people with diabetes. Oftentimes, people do resistance exercise following aerobic exercise. But I remember one study from Japan looking at the hormonal responses. This was looking at the body comp, but performing the resistance exercise mobilizes more catecholamine responses, and then performing the aerobic exercise following resistance exercise leads to better mobilization of fat and then better metabolism. But so that's probably a little bit different. But I think the order for me is not too important for a cardiovascular disease population. Sufficient warm up is needed, but I think it can be performed in either way, and I think the benefits is there by incorporating the resistance exercise, regardless of whether it's happening before or after the aerobic exercise training.
Okay, thanks. I'm going to try to combine 2 questions here before I move to the in-person questions because you're getting lineups. So from Dr. Beelands, it says, thanks for great presentation. 2 questions. It looks like the heart failure studies you showed the meta-analysis for are small. Do you think it's time for a much larger trial looking at outcomes, quality of life, etc.? That's the first, and then I'm going to move to the second. Sorry, you go ahead.
Okay, yes. So the studies included in the review. So I just wondering if it's a number of studies that's included in the review, or the studies had a small sample size in their studies. Just not too wasn't too sure.
Looks like the heart failure studies you showed in the meta-analysis are small. I'm assuming it's number of studies versus number of patients within those trials.
Right. So yes, there are definitely more studies looking at the resistance exercise, but when I limit to the studies that compares randomized control trials that compares the combined training, and aerobic exercise training alone, that does reduce the study numbers and the sample size. So it is more studies are coming out, but yeah, I do agree there are limited studies out there, and that's part of the reason we wanted to pull all these studies and see the effects of combined exercise training in this particular population compared to aerobic exercise training alone. And I hypothesized there'll be some benefits by adding the resistance exercise training. So hopefully I can complete this review and ensure more definitive results soon.
Wonderful. I'm going to pass the mic now to one of our in-person questions, and then I'll go back to the online ones.
Congratulations, Professor Terada. Thank you very much for the amazing presentation. It's also very important because we know that resistance training, in addition to the cardiometabolic benefits, will help with patients' balance and reducing their risk of fall. So that's very interesting. So my question is about home exercise programs, and if you see, according to the literature or extensive experience, differences in terms of machine-based and body weight-based or elastic training, and any thoughts about implementation, prevention of adverse events with home-based programs? Thank you.
Yeah, so I think any forms of resistance exercise benefits, especially clinical populations when they are really naive to weightlifting. So rubber band is great exercise, calisthenic is great exercise. I think machine-based is fairly safe as well. Free weight, they may need to learn a bit more, but regardless of these types, I think the benefits are there. So whatever is accessible, some people don't have access to machine-based exercise equipment. And if that's the case, if they can do rubber bands or calisthenics types of exercise, resistance exercise, I think that's great for them. And then that applies to home-based versus cardiac rehab environments. At the cardiac rehab, they may have access to machine-based resistance exercise, and they can probably maybe do a bit more. At the home, they probably don't have those, so they probably need to stick to more of a calisthenic or rubber band type of resistance exercise. But I think that's a great exercise. So if they can do that at home, I think that will bring them big benefits.
So maybe a hybrid program could be interesting, so they can actually learn how to use, and then they can continue at home in the second phase, maybe.
Yeah, I think that's interesting. I think yeah. So I think many people are looking for the ways to perform resistance exercise, especially if they have not done it before, they don't really know how to engage in this type of exercise. So if they can learn that through the cardiac rehab and then maintain that at home, or if they can do a hybrid form of exercise where they do some part on site and others at home, I think that's a great way to implement exercise for cardiovascular disease populations.
Okay, thank you very much, Professor.
Hi, and thanks for a great presentation. I'm a nurse in cardiac rehab. My question is in regards of not that many cases that we see, but sometimes we see people that they are more interested in resistance training, not aerobic exercises. And they've done that, and definitely they are not really interested in doing, lots of repetitions and with low weights. I was wondering, with people that they are just interested in resistance training, how much they gonna lose on improving their cardiovascular fitness?
So by resistance exercise alone, for when people are fairly deconditioned, there's a benefit to improve cardiorespiratory fitness. And how much really depends on where they are and the different factors. So I can't really say how much, but it does have a positive impact on cardiorespiratory fitness. So I think it's not a bad idea to do resistance exercise. If they only want to do resistance exercise, that's an interesting case. I think I would recommend both, but I think resistance exercise by itself is better than not doing exercise. So if they want to stick to that, and then, do resistance exercise more, I'll say, that's still much better than not doing anything. So ideally add both, but if they just want to do resistance exercise, I think that's one way to improve their health as well. And resistance exercise by itself has lots of health benefits, so may not be a bad idea.
Thank you.
Okay. Oh, no, hopefully I'm not going to break this mic. I will say for those listening online in person, I think Dr. Terada is a bit modest. Some of these publications that he's speaking to have been published in some very high reputable journals and shared, thousands of times online. And so one of the publications that he's featured here is published in the British Journal of Sports Medicine. So if you're interested in learning more about these topics, I would encourage you to find that publication online. It's very well done, and it's gathered quite a bit of interest in the community. I'm going to try to fit in one more question, and then those that we can't, I will share email addresses or comments, and hopefully you can reply to those later on, Dr. Terada, if that's okay with you.
Absolutely.
Okay, so combining two questions here. One of the challenges for exercise programs is sustaining the benefit over time when the formal training program terminates. Are there differences of the different exercise training strategies in terms of adherence or sustainability beyond the formal training program?
Okay, so beyond the formal training programs,
are there differences of the different exercise training strategies in terms of adherence or sustainability? So this question is, I'm assuming, specifically getting to aerobic exercise versus resistance training in terms of sustainability after program completion.
Okay, that clarifies. Thank you. Yeah, I'm not completely sure, and I don't think there are too many studies out there looking at the adherence to resistance exercise following the completion of the intervention or supervision phases. Some people do say, once they start resistance exercise, they keep going. So, but that's kind of anecdotal evidence. So sorry, to be honest, I don't know. Unfortunately, adherence to exercise often does deteriorate over time, and I think that does apply to resistance exercise as well. And my recommendation is for the patient is you just don't walk away, just do a few minutes, just to stay in the exercise. If you don't feel like doing it as much, just try to do a few minutes and make it as a part of your life, and then hopefully that would build up over time. So yeah, I don't really know if that leads to different adherence, but yeah, that'll be interesting to look into.
Okay, I'm going to leave you thinking about these before you reply, maybe via email, which is one looking at resistance training in the aortic disease populations, the repaired aortic disease dissection populations, and the other is whether there is a benefit to adding strength exercise to Nordic walking. So we are out of time today, but I do want to pass those questions along, and then we'll connect you with those questions so we can reply to them. To close, then I want to again thank Dr. Terada for his time this afternoon and sharing his research with us. Thank you for everyone who has attended online and in person. We will have one more cardiac rehabilitation rounds before we close out for the season. So thank you very much, and we will see you again.
Thank you.
I think we lost him on the